Well, ladies and gentlemen, I think it's time that we get started, and some people will go ahead and meander in a little bit late. I want to welcome everybody today, and we'll call the meeting to order. Glad everybody's here. I'm going to do a little bit of a roll call. Bear with me and forgive me if I mess up your name at all. County of Riverside District 3, anybody here? Sunday? She's not here. She's probably caught in traffic. Chuck.
It was bad.
Yeah, that's what I'm hearing. City of Temecula has Mike Nagar and Mary Ann Edwards. City of Murrieta has the esteemed mayor, Mr. Gibbs. You look esteemed. All right.
Esteemed or steamed?
And you're the only one here. Mr. Long's not here?
Mr. Long is not here, but Izzy McGee from the City Analysis Department is here.
Hey there. Good to see you. The fine city of Menifee, our neighbor to the north, we have Miss Lisa Sobek. Hi, Lisa.
You know what they say, don't drink the Kool-Aid. Right?
City of Lake Elsinore, Councilmember Manos is not here. Anybody here from Lake Elsinore? Okay, we'll continue. The American Cancer Society, who's here from American Cancer? Ooh, they must be stuck in traffic because I know they wouldn't be missing this. Okay, Michelle's Place. Everybody knows Kim Goodenough. Stand up, take a bow. Okay, all right.
I'm the mayor of Wildemar, too. Tim here.
Oh, okay. Okay. Is the mayor of Wildemar here? No, I'm just messing with you. Okay.
I wondered why he wasn't at the table.
Yeah, good to see you. All right. And glad you're here. All righty. Inland Empire Health Plan. You guys here? Hello. Thank you very much. Good to have you. Loma Linda University Medical Center, Peter Baker, Cheryl Allred. Hi, Cheryl, good to see you. Riverside University Health System, Public Health. Not here. All righty, Scripps Health.
Tomorrow.
Hi, good to see Alice. Sharp Healthcare. Anybody here from Sharp? Okay. Temecula Valley Hospital. Anybody here? Yeah, that's strange. All righty. UC Riverside School of Medicine. Okay. UC San Diego Health. Okay. And then local doctors. How about Dr. Bremer? Hi, Doc. All right. Richard Chinook. Dr. Chinook. Dr. Heizon. He's on.
He's on.
Dr. Horner. He's usually here. Okay. Dr. Carla. Or Carla. Dr. Mendoza.
I'm covering for her. I'm about to say.
Oh, okay. Thank you. Welcome, doctor. Glad to have you. Dr. Schwenka. All right. And Dr. Spicer. He's in surgery. All righty. Okay, well, that completes roll call, and we'll just update it as people come meandering in. And let's get to the public comment portion of the meeting. This is for non-agenda item. Is there any members of the public here who wanted to address the group on non-agenda items? Typically, there hasn't been anybody. I don't think there is. So we'll move on to committee business. Item 1, cancer patient caregiver testimonials. Who do we have today? David, come on up. We're glad to have you. Welcome.
Thank you.
Do I need this microphone? I do.
You can
Can I stand back here?
Yeah, whatever you like.
So I was asked to speak of my experiences with cancer, and I'll tell you, I started my walk as a caregiver for my mother. I was in the Marine Corps for a number of years, and my last deployment was in 2003. And when I got home, my mother had been fighting cancer for a couple years, living in Arizona. She had ovarian cancer. Living by herself and being in her 70s, I felt it important to be close to her, so I had her move out here. And to move all her treatment here and with her insurance and everything, which we did do. My first experience in living in Murrieta with my mom, I'll just talk before I talk to the goods and the bads, I'll just tell you the story. So my mom lived with me for about 6 months, and she passed away. And I wasn't supposed to do this, so,
It's okay.
you know. But anyway, so for about 6 months, you know, she progressively got worse and deteriorated, and she passed away. God bless her. About 6 months after that, my then wife's father, my father-in-law, gave us a call and said, I have lung cancer. And she has about 5 siblings, but I guess we were experts at the time on caregiving, so then he came to live with us.
Oh, goodness.
In kind of the similar scenario, got him plugged into the healthcare system around us, living in Marietta, and he lasted for about 6 months. So, you know, that's my experience as a caregiver. I will tell you that it was probably the hardest thing I'd ever had to go through in my life. As I'm sure some of you know. I know Rick does. So, watching someone deteriorate and not really knowing good, bad, or indifferent, you know, the quality of care that they're getting, I just went with the flow. Well, about 5 years ago, so that was in 2003, about 5 years ago, so 2011, 12, I had a lump in my throat. And just thought, you know, I had had a cold, this lymph node won't go down. And so I figured, well, I've had this for a few months, it's not going away, let me get checked. So then at the time, you know, I just retired. So actually that was about 2007. And I just retired from the Marine Corps and out living life as a civilian, trying to figure it all out. And I had seen a specialist in Fallbrook who just did a needle stick, told me I was probably just a cyst, you should be good to go. They drained it. He says if it comes back, if it persists, then we can go in there and take it out, because sometimes that happens. And it did. And probably in a couple weeks, the lump was bigger than it had been. And so then I went to a surgery center in Marietta, and they took out 2 golf ball-sized tumors out of my neck that they called me back. And I was in LA at a trade show for what I do. I'm a risk manager. And he just calls me and says, hey, you know, we have to see you immediately. You've got stage 4 throat cancer, and we need to start treatment ASAP. I'm in a room with about 1,000 people, and kind of the floor just dropped out from underneath me. Because all I could think about was the only experience I've had is with my mom and my father-in-law. They lasted 6 months when they were diagnosed with stage 4, and I still had little kids. I had little girls. I say little, they were in high school, junior high school. So I started my walk. I had 2 surgeries on the outside of my neck. I had 4 surgeries down my throat, 37 radiation treatments, and 3 chemotherapy treatments. Last December was 5 years clean, and I've been told, you know, you're cancer-free. So as a guy who's got cancer, I will tell you though, when I said that my mom and my father-in-law, and that was the hardest thing I ever had to do in my life. And I was in the Marine Corps for 30 years. I've been beat up a lot of broken bones, and seen and been places that people shouldn't go. But sitting there as the person receiving the treatment, it was nothing like, I thought I could be a support to my mom, but until you go through it, you don't really know what it is. I weigh about 175 right now. I dropped down to about 130 pounds.
Oh my God.
Of course, I lost all my hair. I lost a couple teeth from the radiation treatments, and I got this sexy Barry White voice for the rest of my life. So,
Sounds really good.
So now that's my story. I will tell you, when I went through the treatments with my mother and my father-in-law, it was out here. And again, you don't know what you don't know. When I got diagnosed, and talking to the oncologist out here, where it was going to happen, where I was going to gain radiation and/or chemotherapy, it was the same place my mom had gone. And I just was, for the first time in my life, you know, I'm a retired sergeant major and I don't know what to do. There's not a lot of people out there that can help you get through this. There's people that can comfort you and they feel for you and they want to give you the big hug, but at the end of the day, you know, this is my life and I've got to figure it out. And so I got a second opinion because I just needed to have a second opinion for my own quality of life. So there was a friend of mine who had gone through City of Hope and then mentioned that there's a doctor in San Diego at UCSD at the Moores Cancer Center. His name's Dr. Brumman. So I went down to see him. He looked at my test results and said, okay, the protocols themselves are not out of the ordinary, but let me walk you into the Moores Cancer Center. So, hey, I'm a public school guy, Mexican from Arizona, and I will tell you, I walked into a room, they're playing pianos, and people are walking up to me asking me if I would like something to drink at a hospital. And I'm like,
Amazing.
well, this is kind of nice. You know, there's couches, and there's just the comfort, the quality of the wellness program, the quality of life, the comfort care that they gave me, and not even being a patient yet, I just knew this is where I need to go get this. And I also said, this is not going to beat me. Did the radiation suck there as much as it's going to suck up here? Yeah, I'm sure it did, because it sucked. Did I feel horrible after chemotherapy for weeks? It's like a flu and a hangover all rolled into one, and it doesn't stop. But at least there I had somebody that I just felt like somebody cared about me. You know, the doctor that I mentioned, he's the one that did a couple of my surgeries. And can I get that water, please?
I had no idea.
Excuse me, but one of the sexy side effects, I don't generate very much saliva, so excuse me for having to wet my mouth occasionally. But he would come in and check on me. And I just thought that was kind of neat because I remember when my mom and my father-in-law went through it, they received their treatments and in some cases surgery, but their doctors would come in, the facilities were what they were, but somebody just, it was like your mission in life just to say, hey, you're going to get through this. And I'm sure I could have found that here with the individual attention, but the facilities that I got to go to in San Diego, I just felt helped me for my recovery. And the person that recommended me, who was also diagnosed with stage 4, she started in her breast and into her lung, she'd ended up going to the City of Hope and also a cancer survivor. And I remember going to the City of Hope thinking, geez, I'd like to just come here and stay. It's like a hotel. So really that's my story. I don't believe I've told that story since I got sick, and don't want to tell it again. But if I can help in any way, and if this task force is your mission in life to provide quality and comfort of care for the residents of this community, these communities, then I'd be more than happy to help you. At this time, do I have any questions?
Any questions? I don't see any, but on behalf of everybody, thank you for sharing your story. It's very meaningful, and I appreciate you also sharing your emotion. We need to, that's why we have these testimonies. It reminds us of the mission and the work that we have to do. So I appreciate you coming.
Just don't tell anybody at the VFW that I got emotional, because I prefer when they're a little fearful of me.
Okay.
The colonel knows, so
Okay.
Rick knows.
Okay, you got it. You have our word on that.
Thank you, sir.
Okay, you bet. Take care. All right, item 2 on the agenda, legislative update. Sounds good. Item 3, understanding insurance Medicare. Scott Brightfuss. Thank you. Welcome, Scott.
Thank you so much. I'm geared up for this. When Andre called me, I speak loud. Better be careful with this.
It's not very loud.
I usually don't
Loud
need
for
microphones. I do speak loud, but Andrea gave me a call from Dr. Hayden's office and invited me to this event. I was thrilled as an independent insurance agent. I don't think there's a lot of people who realize in today's insurance industry how valuable we are to the client. And the difference between an independent agent versus a representative of a company or a big broker house is that we provide personal service. So I started insurance in 1991, 25 years ago, not knowing where health insurance would be today. And I'm a little upset in many areas. And when I was briefed, and again, I wanted to thank Erica as well for having me today. But when I was briefed on what the meeting was to entail, I found that in my expertise in health insurance, okay, I deal with groups of 1 to 100, okay, with group plans. I deal with the individual plans, so I work with the ACA. So I help all these people with all their individual needs and the subsidies and all these fun things that President Obama put into place. And we learned all these things over this 8-year period. And then I got involved with Medicare 8 years ago, and I love Medicare because it truly is a system that is well organized, governed by CMS, Centers for Medicare and Medicaid. The guidelines that I have to follow as an agent is I have to certify with 10 different companies as well as the AHIP, which is the American Health Insurance Plan, and then my scores have to be over 90%. And the reason we take 10 different courses and 10 different companies is I want to work as an agent with no bias. I just want to know the greatest insurance that's offered to my seniors, to my groups, to my individuals. What I noticed in this case, most of all, and my concern, especially, let's start with the Medicare Advantage plans, is in dealing with cancer, and I'm not a specialist in knowing what, I see a lot of EOBs, I see a lot of codes and procedures, and I see a lot of big medical bills, okay? My concern is the drug, prescription drugs, number one, okay, because of the cost of the cancer drugs, okay? And I realize, my goodness, I'm seeing costs between $2,000 and $10,000 a month for individuals. I can't believe it as an agent, okay? But my concern is in some of these Medicare Advantage plans, they only cover, you have sometimes 5 to 6 tiers of drug coverage. So we have your, generics, preferred generic brand, preferred brand, then you have your specialty drugs, and then you have your tier 6 drugs. But the specialty drugs are 33% co-insurance co-payment for the member, okay? So a lot of these specialty drugs that are being used in cancer and all treatments, okay, you're seeing a lot of out-of-pocket for the member. So I think what I have to make sure as an agent is that I have plans that I offer that if I know I have a cancer patient, they're gonna have a low out-of-pocket maximum, okay, because plans vary from $3,400 to $6,700 in out-of-pocket maximum calendar year. So if you put your cancer patient into an MAPD, okay, that has a $6,700 out-of-pocket maximum with a 33% co-insurance on a drug or 20% co-insurance on I believe it's radiation therapy, okay? There's a 20% co-insurance on the, let me get this out real quick. The diagnostic X-ray radiology services I wasn't as concerned with because there's copays under those, okay? So as long as the people that are performing those services are being reimbursed at a reasonable amount. But the Medicare Part B, the chemotherapy drugs, in any Medicare Part B plan, it's 20% coinsurance, and that's standardized in most plans. So I just want to make sure that my job as an agent is to inform my client to have a low out-of-pocket maximum. I'm not sure how much we can do as an insurance industry to ever change CMS guidelines, plans that are standardized that say you have to pay a 33% coinsurance for a particular drug, or 20% coinsurance on all these. And see, this is why I'm seeing that a lot of these Medicare patients that are coming to me are saying, my gosh, I can't afford this money. I'm living on Social Security, and yet all these coinsurances are out there. And they're mostly related to cancer. Okay, so that for me is the downside of what I bring to you today, okay, and my concern, where the insurance industry is not giving what everyone in this room does to help people treat cancer, okay, it's unaffordable for those people, okay? And then when you get into the group aspect, it's similar, okay? When you get into the, oh my gosh, I'm sorry. When you get into the tier 4 drugs, it's similar, okay? Also, my concerns are these doctor networks, okay? I'm running into all kinds of problems fitting up doctors and these people's doctors, okay? And that's a truism. But I must say one thing on a positive note, because a lot of this I've stirred up is on the negative side. The positive part is in California, we have the best choices of Medicare Advantage plans. I also offer Medicare supplements. I'm versed in Part D drug plans. Okay, and then I also encourage people, if you're on Social Security A and B only, and if you know of anybody that's just on Social Security A and B, do not have a supplement, do not have a Medicare Advantage plan. They're looking themselves to open themselves up to a catastrophic event that completely could wipe them out for a lifetime, okay, of everything they've worked for. So traditional Social Security, those types of coverages are virtually obsolete. So do we have any questions I can ask or answer in this case right now? The donut hole, I think was brought up real quick. I'm going to touch on it. And this is really the big concern again. What's nice about the donut holes, it's closing, okay? So what we have is when you have a patient that has cancer and has these copays and drugs that they're spending each month, okay? Well, what you have is, let's figure it at $1,000 per month on a cancer drug and a copay, okay? Once they reach $3,750 on out-of-pocket cost between the current cost of the drug and the copay, they go into a donut hole of about $1,200, of which the member is responsible for 50% of the generic cost of the drug or 41% the cost of the brand drug, okay? Until $1,250 of that drug cost is spent, and then they go into catastrophic coverage. So that's a good thing in a way, because what's happening is the donut hole is closing. 2 years ago it was $1,800, last year it was $1,500. This year it's $1,200, next year it'll be $900. It's all going to go down to $300. So eventually I think the donut hole is going to go away from what I'm being told. So that's another good thing for seniors. But again, just to wrap it up for me, my biggest concern are these specialty drugs and the chemo drugs, the 20% coinsurance on those services. So thank you.
Thank you for coming. You know, first of all, are there any questions for our speaker? Very good. Maybe, yes, go for it, Doc.
What did you mean by coinsurance? Could you just sort of,
Coinsurance?
yes.
Okay, the difference between a copay and a coinsurance is when we have a plan that has services that you're providing that are chemotherapy services, okay, and the chemotherapy.
You need to talk in the mic, please, because we're recording
Okay, I'm
this.
sorry.
Yeah, that's all right.
Okay, so it's listed in an MAPD as Medicare Part B drugs, chemotherapy drugs, 20% of the cost. Okay, so what's the typical cost of a chemotherapy drug?
Well, I don't think there's a typical cost. I think it varies, you know,
So let's say a drug were to cost, could a drug cost $1,000?
Yes, it can.
Okay, so let's say you have a chemotherapy drug that costs $1,000, you'd pay 20% coinsurance, so the member would pay $200 towards the cost of that drug.
Now, would that be if the patient has Medicare only, or is it Medicare plus their supplement?
Well, there's a difference between a supplement and an advantage plan.
Okay.
Okay, and
So you're only talking about the Advantage plan?
I'm talking about mostly about advantage plans because the majority of people with the advantage plans, what's nice is they're entitled to Part A. They pay a Part B premium when they become 65. Okay, that entitles them to the Medicare Advantage plan. Typically in the county of Riverside, it's a 0 premium plan. So it doesn't cost the member any premium to enroll in these plans, except they must be enrolled in Part B. And the nice thing about it is it covers the aspects of hospitalization, Part A, Part B, which is your 20% coinsurance and physician services, and Part D, which is your drug card. Amazing drug cards on these prescription drug plans. The supplement costs monthly premium. You have to pay your Part B premium. You also have to have a Part D drug card. So typical average cost, I'd say for 65-year-olds, about $350 a month for a supplement with your Part B premium and a Part D drug card. So those are the differences, yeah.
Thank you.
Thank you.
Okay?
Yeah, maybe,
Thanks.
thank you. And
Thank
maybe
you.
sometime in the future, if you have a chance, maybe some literature, I'm sure you have plenty of it.
I do.
That you can provide to the group that really just sorts out, and that simplifies it, because when you get into the Social Security, A, B, Medicare Part, a lot of terminology, a lot of lingo, a lot of acronyms, and in all honesty, it goes right over a lot of people's head. And as I was saying at the last meeting, unless you are in it or need to have it, Medicare's on nobody's plate. But we're all heading in that direction. So could you provide that for us in the future?
No, I'd love to provide that, provided you invite me back and stay near the microphone and learn how to use this thing.
Sounds good. Sounds like a winner. Thank you so much.
All right, thanks
for
very
being
much for your time. Thank you.
Okay. Let's see, item 4, formation of subcommittees discussion, subcommittees overview of proposed subcommittees, followed by requests for volunteers to join subcommittees. So Eric, I'll turn this over to you. Looks like you're on a mission here with several things.
I'm on a mission to get everyone out on time, pretty much. So we have a lot ahead of us today. Thank you all for joining us. Just a quick reminder, our next meeting is July 27th. You'll receive updates just like you did for this one, so no need to worry, but just wanted to get it on everybody's radar. The first thing we wanted to touch upon in the staff report today was the funding update, and then as Councilmember Nagar indicated, we wanted to go into a discussion of the formation of subcommittees. We have 4 subcommittees we're going to discuss today, one about health coverage, which Scott just spoke to, one for the formation of a foundation to provide financial support to cancer patients, a third on legislative issues, and the final one I'll turn over to Hark, our facilitator, to discuss the community health needs assessment. For our funding update, the only changes are the items you see highlighted in red. As you know, last time the cities of Menifee and Murrieta had applied for competitive WRCOG Health Beyond grants. Because WRCOG received requests for funding in excess of the funds available, the decision was made to award $6,000 each to the city of Menifee and Murrieta, slightly less than the $7,500 they had requested. And again, we thank everybody, all of our partners, for their pledges. That brings our total pledge support up to $82,000 for this project. Now, to discuss the formation of the subcommittees, essentially, as you can tell, we have so much to cover here, and given the enormity of the task in front of the task force, in order to maximize everybody's expertise and minimize the burden on their time, what we wanted to do was propose that we designate subcommittees to go into some of these tasks a little bit deeper. So we could do, for instance, a deep dive on the topic of health coverage, which really could be its own task force, obviously. I'll just do a brief overview and introduction of each, and then when I turn it over to Dr. LeCompte-Heinley, she will direct kind of the actual process of getting nominations for those subcommittees. For the topic of health coverage, we had our update, obviously, from Scott, which we really appreciate. Thank you. That topic it takes a special interest in mind, I think, to really be willing to dive into those details, and hopefully he'll be willing to support us with additional information as we go through this process. In the update you received from Hark via email, I think about 2 weeks ago was your secondary data analysis went out. We saw that we have an average of 9.1% of the population in the Southwest Riverside County Task Force region is uninsured. Now, that's just the average. As you'll see, it really varies considerably by region. A lack of health insurance has a direct impact, not just on someone's sort of experience of cancer, but it means later diagnosis. It frequently means less treatment options. It means less additional support, and it actually impacts mortality. One national study showed that they saw an increased mortality in the uninsured between 41 and 97%, even once accounting for other factors like comorbidity. In addition to that, even those who are underinsured, so they may have Medicaid, for instance, show a significant increase in cancer mortality at 5 years compared to those who have private insurance. So for that reason, this health coverage topic is really part and parcel of what we're discussing here. These are a few maps that HARC pulled together for us. The first one shows Menifee. The darker green, the less coverage. So that dark green area in the upper right actually has an uninsured rate of between 25 and 30%, which is really significant. You're looking at, a quarter to a third of your population who's uninsured there. Here's a similar map for Murrieta. Again, the yellow has an uninsured rate of between 2.5% and 10%, and then it goes on up from there up to about almost 20%, 19.9%. Same thing for Temecula. The darker the color, the worse the coverage. The next subcommittee we wanted to discuss was the creation of a foundation to provide monetary support or financial support to defray patient out-of-pocket costs. And this was brought up at the last meeting at the request of Dr. Evelyn Mendoza, who unfortunately is not here with us today, but has sent someone in her stead, which we appreciate. So the goal now is to form this foundation that could actually help defray some of that monetary impact. As you know, medical bankruptcies, I'm sure, Kim, you've dealt with this issue. Medical bankruptcies are a very real thing, and that's something we need to think about. Our hope is that this subcommittee would investigate the legal, financial, and procedural aspects associated with creating a foundation. To that end, Betsy was able to provide an excellent legal resource for us, Mr. Philip Oberhansley, who's an attorney. He's had over 30 years' experience in Southwest Riverside County, particularly in contracts, entity formation, basically what we need to know to get this foundation underway. And generously, he is more than willing to work pro bono for us, which we truly appreciate. He's not here this evening, but when we form the subcommittee, he's more than willing to participate and support us in this process. The third subcommittee is the legislative subcommittee. This will track relevant state and federal legislation. You may remember at the last meeting we had the discussion of Tanya's Law, which is sponsored by Tanya, who passed away, her husband, J.J. Petchel. Also, there was some discussion, Andrea brought up some concerns about AB 265. This is where I'll do that legislative update we had in agenda item number 2. AB 265 is currently, it's been amended and it's in appropriations. This was called the Wood Bill, and there was some concern that it would impact patient out-of-pocket costs negatively. Right now, however, it's in appropriations, and there's no indication. It may not even make it out of appropriations. So at this point, it's just sort of on the radar. But what we would like to do is form a subcommittee which could then really keep this front and center for their focus so that they could bring back to us any issues we might not even be aware of as it relates to patient access, affordability, availability, research, and funding. The final subcommittee we wanted to discuss today was the subcommittee that will help structure the community health needs assessment. And for that, if there are no questions, which I'm open for, I'll just turn it over to HARC.
Are there any questions for Erica? Seeing none, let's go ahead and turn it over to HARC. And then Erica, I presume you'll come back and give us your preference on how to form these subcommittees?
Actually, I'm going to leave that to Jenna, if that's okay. I
Yeah.
think she has a plan in mind.
Sounds
So,
great.
Thank you.
Thanks.
Let's see. A plan might be putting it loosely, but we'll work something out that works for everyone. So about a week ago, I emailed out to all of you, which hopefully you all got, our report. Oh, not that close. Our report on the secondary data that we've gathered about cancer and the experience of cancer in our local community here. It is the very beginning of the iceberg, and so I wanted to briefly go over the results with you today because I know many of you are extremely busy and probably didn't have time to read the report. You can also pick up, if you haven't already, the infographic version that just touches on the very highlights at the registration desk. So our first step in any needs assessment is to make sure we're not reinventing the wheel. What have other people studied already? So what do we already know? And what data exists that we can better understand what it's like to have cancer here. So we gathered data from many, many different reliable sources. And the goal of this is to really say, okay, well, this is what is known. what isn't that we need to know, and that is what will drive the development of our survey. So we did 3 general sections, one on incidence and prevalence, one on mortality, and one on treatment options. So prevalence is the number of living people who have had cancer. That might mean they are currently in treatment, that might mean they're survivors, but that's living people who've had cancer. And we found estimates that about 6.1% of local adults have been diagnosed with cancer of some type, excluding skin cancer. And that equates to more than 22,000 adults in your local region here. So this is very similar to the rates in the US, but as you can see, you've got thousands and thousands of cancer survivors here. This is a very relevant issue. Incidence is the number of new cancer diagnoses each year. So this is, of course, something that we hope goes down. Our incidence rate in Riverside County as a whole is 410 cases per 100,000 people. Compared to California and the US, that's actually a little bit lower. And so people living in Riverside County are less likely to get cancer than those living elsewhere. And it has been falling, fortunately. Our 5 most common types of cancer in the county are breast, prostate, lung and bronchus, colon and rectum, and skin. And extrapolating from countywide data down to Southwest Riverside County, we have a little less than 2,000 new cases of cancer happen in this region every year. So again, this is something that affects thousands of people, which is why all of you have come together here. Our cancer rates in general are about the same as California and the US, or better, with one exception, and that's skin cancer. We see this, it's because we've got such gorgeous weather that people are outside a lot more, and they are more likely to get skin cancer. And most of our cancer incidence rates are either staying the same or going down, with the one exception, and that is skin cancer. So not only do we have a higher chance of you getting skin cancer, but it's been increasing over the past few years. Mortality. Our age-adjusted death rate in Riverside County is about 155 people per 100,000. And this is a little bit higher than in California, but not really statistically significant, and significantly lower than the US. So fortunately, people in this region are less likely to get cancer and less likely to die from it. So cancer deaths here are fairly stable. You have an average of a little over 900 cancer deaths per year. And Salome's not here, but a lot of this data on the deaths is thanks to epidemiology and public health. And about half of our local cancer deaths are due to cancers of the digestive organs or cancers of the respiratory and intrathoracic organs. Median age of death in the region is 73, so this is something that disproportionately affects seniors, which is also why talking about Medicare is so relevant. And thank you to our speaker from earlier. Now, Erica mentioned this, is that about 9.1% of the population here is uninsured, meaning that they're going to have a really tough time getting that cancer screening and prevention because you don't go for regular checkups if you don't have health insurance. We also, once you have health insurance, it's not enough to just have it, right? You have to go to the doctors, and there has to be doctors for you to go to. Here, locally, there is a lack of primary care providers. The Office of Health, I don't know what OSHPD stands for off the top of my head. It's in the report, though, so I promise I didn't make it up. But it is officially designated that this region is a registered nurse shortage area, a primary care shortage area, and most of it is a medically underserved population, meaning you have low-income, high-risk patients and not enough providers to treat them. So this is indicating that there really is, even once you have insurance, there's no guarantee that you're regularly getting to your primary care provider to get those important cancer screenings. Cancer screenings in the region are doing a little bit better than the US as a whole, but there's still quite a bit of progress to be made, and these are just the recommendations on three of the major types of cancer screenings. 2 are specifically for women, and the other is, for, generally speaking, for people over the age of 50. So according to OSHPD, there were roughly 1,000 oncology surgeries performed on patients living in this area. So that's important, is that the patient's home zip codes are here in Southwest Riverside County. So they're living here, and about a third of them are getting their surgeries done here. So that's a definite plus. They're not having to leave, it's local. Another third left the immediate region, but they went to places like Riverside and that sort of places for their oncology surgeries. And the remaining third left the county to get their surgeries. And if you look in the full report, I detailed out some of the major hospitals that they are going to for those surgeries. So I know this is essentially why this cancer task force was put together. Am I too close to it? Oh, okay. All right. I know this is why the task force was put together, is this idea that people who are living here who are experiencing cancer have to leave the region in order to get their services, and that out-migration is really troublesome for them. And you know, it's putting up major barriers when at a time in their life when you hope you can eliminate barriers. So there's no data out there about why this is happening. We looked at a couple different things on potentially why it might be happening. One, and in the report I sent you, it said 19 oncologists, but thank you to Robin, who's back there somewhere, for correcting me that 2 of the oncologists listed in that report have since left, so I've updated it. And that's an important thing to note, which I should have started this off with, is this report is a draft. If you have additional information or feedback on it, I would love, love, love to hear it. I want it to be the best it can be for you. So please do shoot me an email, say it out loud now, anything like that. And thank you to Robin for proactively doing that. So having 17
Kim, I think you had a question here from Kim. Go ahead.
Oh, yeah.
On the oncologists, are these full-time oncologists in our community, or are these people that just come here once out of San Diego County and have an office in Riverside County?
That is a very good question, and I should have broken it down. I initially put in how many had multiple offices, but some of the multiple offices were multiple offices still within the region, you know, somebody in Wildomar and Murrieta. And so some of them definitely have offices out of the area, and it's unclear to me, at least just looking on the internet, right, which is their primary location that they practice out of. So this is essentially by doing the type of Googling that a patient would do, this is who I could come up with. And so I'd love, again, those of you in the region and those of you who are practicing, I'm sure have a lot of great input for me on that. So it doesn't seem like we don't have enough, but it might be an awareness issue, right? Is that when you're first diagnosed with cancer, you're not Googling on 12 different sites to figure this out. You're overwhelmed and a little bit in shock. The other potential reason for out-migration might be this perception, this prestige seeking. Our local hospitals here aren't on the major lists that are, again, just what a patient might Google. National Cancer Foundation, American Cancer Society was recommending, okay, well, here's what to do when you're looking for treatment. And one of the things that they recommend is you look for accredited centers. Well, we don't have any centers who currently have any of these accreditations. Not to say, and doctors in the audience, the hospitals may be pursuing these, which is excellent, but there may be a perception that, okay, well, I just got diagnosed with breast cancer, I want to go seek an accredited breast center, and there isn't one in the Valley. So that might be a reason for out-migration, but there's a lot of other reasons too. I was talking recently with a close acquaintance of mine who's been diagnosed with prostate cancer, and he chose to leave the county to get treatment. And a big reason for his was the rapport with doctors. You know, he just fell in love with this particular doctor. He feels so comfortable, and that's where he's going to seek treatment. Or your story about the sort of the luxury of the treatment, right? That really was very, very appealing to you as a cancer patient. So there may be a lot of other reasons for this out-migration, which we will explore in the upcoming survey. So our next steps is to design a study that will find out these gaps in information. What are the reasons for outmigration, but also what are the barriers to care? What can we do in addition to, say, the foundation that can make life easier? So we'll be doing 2 studies that are separate but very much designed to be complementary. The first is a community study. So for people who are patients, who are survivors, who are caregivers, whose lives have been impacted by cancer, tell us what those barriers were. How can we make life easier? And then also for the providers, because I think those are 2 sides of the same story that fit together really well. So this 4th subcommittee, and Erica went over the first 3, this subcommittee, whenever HARC does a study like this, we rely really heavily on subject matter experts because we're the experts on data and all things data geeky, but you all are the experts in terms of understanding cancer in this region. So what we want our subcommittee members to do is help us to design a survey that asks the right questions, so we're getting the right information that you really want to know. We're using the right language. And we're reaching potential participants, and we're doing, this is really important for this particular survey, is making sure that it's the least burdensome for people who are living with cancer, because the last thing we want to do is make life tougher or more complicated. So for this subcommittee, in meetings, you'll be asked for your feedback and input on survey drafts, to review it, provide revisions, provide guidance, and do that in an iterative fashion. Also to identify how should we best collect this data and get the word out and tap some of your networks about how we can get the word out and collect data. So in terms of setting up these 4 subcommittees, I don't have a very formal plan. My plan was essentially to ask for volunteers, and I think each subcommittee should have 1 official person from the task force, but also this is a great opportunity for those of you who are supporters to really become actively involved as well, because you're here because you care about this, and this is a great way for your input to really be heard. So, Erica, does that sound?
Yes, I think that sounds like a good plan as long as the task force is in line with that. My only concern is because we have low attendance today, we may not have the representation that we need. At the same time, I don't want to defer this process any longer, obviously, because it's very time sensitive. So I guess I'm just sort of looking for feedback.
Yeah.
I too have some concerns on the low attendance. I think there's people who aren't here who'd like to participate, and I think if we didn't include them, it would be our loss, to tell you the truth. So, some thoughts. Do we want to table the selection till the next meeting? Do we want to solicit it via email? Both? Any other ideas, thoughts? Turn on your mic too, because we're recording all this. That's okay.
I would say we solicit it via email, just because if these people in the room now aren't here, we might lose them as well. So we could ask now, but also solicit via email. And I don't know if tabling it is necessary. I don't think we should table it and stop it. We want them to keep going.
No, that's a good idea. If everybody's in concurrence, and I assume they are, why don't we proceed in that fashion?
That sounds great. So,
And do we have descriptions of what each committee is going to be doing and the tasks and all that?
we have that for the community health needs assessment, but Eric and I will put together that very specifically. We went over it briefly, but what to expect both in terms of tasks and time commitment.
Perfect.
And put that together along with some of the language from Erica's slides earlier on why do we need a subcommittee for this and why is this important. HARC will send that out to, if it's okay with you, to the task force and all stakeholders to ask for volunteers to join that, if that works out for all of you. And it's my vision that these subcommittees will be very fairly informal. So for instance, I know with ours, like I said, a lot of it is reviewing and revising. So if you can't come to a meeting, that's fine. I still would love to hear your feedback, if you have a chance, and send it via email type of thing. So I know everybody here is very, very busy people. So it may be that you drop on and off depending on your schedule, but as much participation as we can get would be wonderful. And Of course, if you're passionate about multiple, please join multiple. There's no such thing as too many invested people in the room. So, T, are you making a note that I need to send that email out? Okay. All right, and then just to wrap up, I wanted to do a refresh. You all saw this last time too, but this is our timeline for the community health needs assessment. Now that the secondary data is gathered, and again, our reports are not final. I welcome any of your feedback. If you haven't had a chance to read it already, feel free to do that this week and send me feedback. We want this to be the best it can possibly be for you. Then we'll go right into designing our surveys, and that's where this wonderful subcommittee will be really, really useful for us, and get started on data collection, because this is a very resource-intensive project, and we do want to get done in a timely manner. Oh, yep, and that was the end of my slide. Okay, I will turn it back over to Mayor Edwards and Councilmember Nagar.
Thank you. So I'm kind of going to bat it back to you. How do you want to proceed? Shall we, obviously you'll send out an email in relation to the subcommittees, and yet you still want to solicit interest now, correct? So why don't, if that's the case, why don't we go
Sure.
through them one by one?
Yeah,
Is that what you're hoping to do?
that sounds great. Let me
Can I add
pull
something as well?
Oh, go ahead.
Erica's slides back up with the list of the 4. Okay.
Can I add something? real
Yes,
quickly?
please.
So I'm definitely interested in the needs assessment committee, but I am concerned about the commitment, so I don't know, I'm kind of hesitant about volunteering my time until we have kind of more information on the committee, but just want to let you know, I think an email is going to be very helpful in providing that information before you're going to get a lot of commitment, I think.
Right, absolutely.
Okay.
So if you don't want to volunteer today, but once you get the email, you're jumping on board, that's great too. So honestly, you know,
I'd also like to add the same thing, that, I mean, we need to flesh out what is required of us and how we can be of help. And I think, from what I can gather, that hasn't been done so far. Is that accurate?
it has not been, I mean, this is a brand new
Right,
concept of
right.
the
So
subcommittees.
I think even though we would like to solicit people now, I think it's also important that those people know exactly what they're getting into so that they
Well,
can.
well, yeah, but let me
Okay.
see if I can help with that,
Great.
because with the subcommittees, and boy, we do a lot being on the city council, we're always very sensitive that we don't meet too often and we don't meet for nothing. Okay, so I'm gonna guess that on the outset, I'm just gonna take a guess,
Please.
maybe an hour and a half meeting once a month, maybe an extra one at some point, another hour at another meeting for maybe twice a month, but I don't see that going
No.
more than that.
No.
So that's probably the depth of it. Maybe in between the meetings, you'll be weighing in via email, giving your input, things of that nature. Yeah, so that's probably the long and short of it. I don't see you at, 3 meetings a week or 2 meetings a week for 4 weeks straight or something. It's not like that.
Does that go along with the timeline that has been outlined for, because I gather, at least from the HARC, June is when they start getting the questionnaire, July is when they start gathering the data. So will an hour's meeting be sufficient to do that?
For me personally, I find that typically when we do this, a meeting is great to get everyone on the same page, but then a lot of times it's more functional and productive to have you review something and send it via email.
By email?
Because, it's very nitpicky, right? It's you saying, I wouldn't frame it quite that way, or you saying, that's not relevant. So honestly, having it written is more useful than really you telling me and me writing it down. So for that particular subgroup, I think it would be sort of a meeting maybe once a month, and then the rest would be via email, assuming everyone is responsive to email. Now, the foundation might be a little bit more meetings focused, because that one I could see it being very useful to have various people present, right? We've got this lovely pro bono legal expert who will come talk to us about the legal implications of starting a foundation. We've also got Paula Simons, who's the executive director of Desert Cancer Foundation, which does this very same function in the Coachella Valley, who's willing to come talk about what it's like to actually operate such a foundation. So that one might be a little bit more meeting focused. However, that's not on quite such a tight timeline, although I know you all don't want to drag this project out forever, and you want something actionable relatively fast. Also, the legislative issues, I could see that one being less meeting intensive, because that's more doing research, making phone calls to your representatives, that sort of thing. So when I do the email, I can put together sort of a estimated hours of in-person meetings versus homework in between meetings that will help you make those decisions, because I know you're all very busy.
And another tool I think we can use is conference calls.
Yes.
Yeah.
Yes.
I think that would be very helpful as well. And I'm with you. You know, so many meetings, they can eat up into your day before you even blink. So you know how that is.
So do we have anybody who is especially passionate about one of these and says, I want to be involved in this one in some way, shape, or form because I'm super passionate about, say, healthcare coverage?
Well, let's take them one at a time. Why don't we just do that? So float, the first one is, which one is
So the first
health
one is
coverage?
healthcare coverage, and so that's understanding Medicare and exploring, you know, what sort of this task force can do to
I will volunteer for that one.
Okay, great.
What? No, I'm 55. Okay, I have selfish motives. Okay.
And hopefully, Scott, you'll be willing to. You would not be asked to head it, but we would love your input and. Wonderful.
Sure, yeah.
That would be wonderful. Thank you so much, Scott.
Anybody else on health coverage? Okay, let's
Okay.
go on to Cancer Patient Support Foundation.
So this is really at the behest of Dr. Mendoza, so I'm preliminarily guessing that she might be interested in joining this. And this is the idea that, as we've heard at the last meeting and at today's meeting, some of the financial costs are just absolutely, just will grind you down, even if you do have good insurance. And so looking into whether or not this task force can establish a foundation that could alleviate some of that financial distress. Oh, Paul? Yes, wonderful.
Put me down on that one as tentative as well.
Tentative.
Tentative
Okay.
on that one.
Sounds
yeah.
good.
Yeah. No, because if I take it on, I'm going to do it, and I have to weigh my time. So, anybody
about-
else on
Yeah,
Patient Support Foundation? Okay, legislative issues. So we have
All right.
Mayor Edwards and Mayor Gibbs.
Okay.
Okay.
We also thought that Darlene might be interested in that one.
Yes.
I know that the hospital tracks a lot of their own issues.
Yes.
Okay.
Not here today, but I can tentatively reach out.
Good. That's where the email will help.
Yes, absolutely.
We'll go for it. Yeah, well, let's ask this question. We're not limiting the members here.
No,
yeah,
no.
So,
Absolutely. And, you know, if something happens and you have to back out, we all understand that too. So,
do you, Councilmember Sobek, would you like to be on that one?
That would be great.
So add Councilmember Sobek to that one.
alrighty.
Mike, I can give you an example of the legislative. At the last meeting, J.J. Prechtel took the microphone, he talked about his story, his wife's story. I was touched. I went up to him afterwards and I said, you and I need to speak. I had the opportunity to talk to Jeff Stone, and Jeff said, I got 15 words out about what JJ had to say. What he was talking about in terms of Tanya's law was in California, trying to make it a law that every patient should be advised that they have a right to ask for DNA and to be advised that there is personalized medicine. It may be too expensive for them to afford, but at least make them aware of it. So Jeff, when I talked to him about it, after 15 seconds, said, I'll sponsor a bill.
Yeah.
It was as simple as that.
That's an easy one, too.
I put JJ in touch with Jeff's office. Jeff made time to meet with JJ. And at the same time, the other option that JJ was looking at was a ballot measure. And I put him in touch with my son, who was the American Cancer Society guy who put together the ballot measure that passed about increasing the tax on tobacco. So by the way, it took my son 3 different attempts to do that, since Big Tobacco spent $100 million usually compared to the $5 million American Cancer had to spend. But one of the things that came out of that conversation with my son was, unless you have a really large war chest, it is difficult to get a ballot measure passed in California, and that by pursuing the legislative route through Jeff Stone's offices,
Yes, that's better.
that's probably the best way to go. So, the other thing that has not borne fruit yet is I talked to Brenda Denstead and said, I want to see Calvert. And because what I want to ask him is, can you get me in to see Scott Gottlieb? And because I'd like to talk to Gottlieb about the same issue, about making sure that that we, as a nation, especially for cancer patients who are on stage 4, that we don't delay the the ability to participate in clinical trials, because we all know Europe is better at getting clinical trials started than we are in the United States of America.
Mhm.
So, anyway.
And Senator Stone had a similar bill called the Right to Try, which would have allowed patients who have reached that stage and have other modalities have failed, and they really have nothing to lose by trying drugs that aren't all the way through FDA approval, but have reached a certain stage of FDA approval. So.
Wonderful. Well, thank you. And then the last new subcommittee would be the Community Health Needs Assessment. So looking at what exactly those tools look like, what does the data collection look like, and how can we get it out to the most amount of people possible. Amy, thank you.
Yeah, Amy, and Kim and
Kim?
Marilyn? Yeah, those.
Paul, thank you.
Very good. That, I believe, is probably a very, very important subcommittee.
Well, I think that's really
That's the nuts and bolts of why we're here, yeah.
it really
Yes.
is.
Yeah.
I mean, of course, I'm biased. That's my personal favorite. But yes, thank you all very much. So I will work on crafting that more detailed email and get that out to you early next week so that we can keep moving forward on this and get our subcommittees finalized.
Very good.
Any
Very good.
questions?
Any questions? No, I think
All
we're
right,
good.
I'll turn it back over to
Can
you.
I ask one quick
Yes, of
question?
course, yes.
Of course.
So when these subcommittees are formed, do you have a quorum that you need?
That's a very good question.
Because I'm wondering if it's not limited as the number of people who are there, then maybe you can tell me what the usual.
No, no. The quorum is usually when you're being very formal.
Okay.
Okay, maybe working with articles or bylaws, or in the case of.
And making binding decisions,
You know,
really.
cases of cities, things like that, we need to have a quorum. So the answer is no. Now, having said that, if you got a committee of 7 people and 2 show up, you know, the whole purpose of having several people on the committee is we need everybody's input. And frankly, I love everybody here, even a lot of people in our audience members, to be part of it. I think the real important thing is consistency, that you've been part of this from the beginning, because it's hard to get up to speed if you don't know what's been going on. But no, there's no problem there. And you know what? We hold meetings here all the time where 3 people are here live, 2 call in from conference calls, you know, and one will say, yeah, via email, you know, or something. So we'll get it done. But everybody's opinion is real important.
That's a really good question, though.
Yeah.
Quorum is often a deal breaker in terms of what can get accomplished, yes.
Anybody else? Any other questions? Okay. Anything else?
All right, I am done. Thank you.
Okay. All right, then we'll move to item 5, closing remarks. I don't really have much to say. Does anybody have anything to say? Oh, well, hey, say it.
Have a great Memorial Weekend.
There you go. With that, I don't think of any better way to close. If there's nothing else, see everybody at the next meeting. Thank you.